Thank you very much. Good morning, everyone. I'm Shereen. I'm a rheumatologist practicing at Hospital Selayang here at the Klang Valley. So Hospital Selayang is a tertiary referral center for rheumatology in Malaysia. Firstly, I would like to say thank you very much to Mr. Azrul and the Galen Center for this invitation to be here with all of you this morning. I'm very honored actually to present today on the topic of the rheumatologist's role in the management of interstitial lung disease, and just to bring the perspective of how we come into the picture in the management of interstitial lung disease. Okay, sorry. So firstly, maybe I might just give a brief introduction of what it is that rheumatologists treat. So you've been hearing this term connective tissue diseases, or CTDs. So what are these CTDs? So CTDs are a group of closely related immune-mediated diseases and with an underlying inflammatory process affecting the connective tissue diseases. And if untreated, it can cause organ damage and ultimately death. So amongst all these CTDs, there are actually many overlapping features, but we can differentiate them based on some specific clinical manifestations as well as subsets from autoantibody tests. So how does CTD-ILD come into the picture? So there are many ways, that the lungs can be involved in these CTDs. So as I said before, these CTDs, they affect many systems, they can affect many organs, and the lung is one of them. And how the lung can be affected in CTDs, it can be affected directly, direct involvement, for example, through an inflammatory or fibrotic process in the lung itself, or it can be indirectly. So for example, if the patient has involvement of the respiratory muscle, so if they have inflammation in the muscles, then this can cause hypoventilation and then difficulty in breathing. Or the involvement can occur as a result of complications from treatment that we give to the patient. So one very common complication and something that we often watch out for is infection. So as Dr. Shakirin mentioned earlier in her talk, tuberculosis, that's quite something that bugs us quite a lot because we give our patients a lot of immunosuppressive therapy, and tuberculosis is endemic in Malaysia. So this is something that we always need to watch out for in our patients. So in what ways can the lungs be involved in CTD? So all parts of the lung can be affected. So it's not just the lung parenchyma, but the airways can also be affected, and also the vessels and the pleura, which is the lining covering the lung. But interstitial lung disease is fairly commonly seen also in our patients. So amongst all the CTDs, the CTD which is most commonly affected with interstitial lung disease is scleroderma, or systemic sclerosis. You heard Dr. Felix mentioning this condition. Scleroderma is a relatively rare CTD, but ILD is common in scleroderma. The other CTD which has commonly has ILD as its manifestation is dermatomyositis and polymyositis. These are inflammatory muscle conditions. And then, of course, also seen in rheumatoid arthritis. So amongst all the CTDs, rheumatoid arthritis is the commonest. It affects about up to 2% of the population. And then, of course, we have the other less common CTDs with ILD, which are Sjogren's, systemic lupus erythematosus, or SLE, or lupus as it's commonly called, and mixed connective tissue disease. So why is it important to talk about CTD-ILD? So this slide here shows the prevalence across the board of CTD-ILD. And we know that it varies, the prevalence varies. So as you can see, the figures here. So in scleroderma, the prevalence is thought to be around 70 to 90%, down to about 10 to 30% in Sjogren's and 2 to 10% in lupus. So the prevalence varies. But we know that patients with CTD-ILD have a worse prognosis compared to those without this condition. So it's a condition, as you've been hearing about, it carries a lot of morbidity. It affects their quality of life, affects their function, and also it affects the mortality. And I very quickly just had a quick look at the data that we recently presented at our national conference. And this was an initiative by Prof. Raja Jasmine at UMMC. And she and her team collected the data from all the rheumatology centers in Malaysia, most of the centers anyway. And we had about over 300 patients with systemic sclerosis, ILD. And surprisingly, the median age of survival was 39. So CTDs generally affects the younger people. And these are people in the productive age, women who are childbearing with families. And of course, this data is from the last 20 to 30 years. And so therefore, we know that it carries a lot of, the prognosis is not good, isn't it? If the median survival is only 39. Okay, so what is the role of rheumatologists? What do we bring to the table when it comes to the management of ILD? So in terms of diagnosis, well, we've heard that patients present. They don't come and say, okay, I'm a case of CTD-ILD, isn't it? They come to the doctor and they just say, oh, I have a cough, or I've been feeling a bit breathless, or a little bit more tired. So it's a very non-specific kind of symptom. And some of these patients actually may turn out to have an underlying connective tissue disease. So they may have ILD, but the underlying pathology or the underlying reason is a connective tissue disease. So then, of course, this is where we come into the picture. So we can help in terms of pattern recognition, because these patients, I often tell patients, how do we diagnose a CTD? It's not as simple as doing a blood test. So it's a recognition of various clinical manifestations, and it's a constellation of symptoms and signs, and then eventually we come to a diagnosis. And the other thing that we have an expertise on is also on the interpretation of the blood test results. So many patients might go to their doctor and do some screening test, for example, and it might come up as, for example, an autoantibody test comes back as positive. But not everybody with positive autoantibody tests has a CTD. So this is where we come to the picture. So we will look at the results, look at the patient, look at the symptoms and signs, and then provide an interpretation on the significance of it. So in terms of management, yes, we work together very closely. So you've heard a lot about multidisciplinary management of patients. So patients, as I said, CTD patients, they have multi-organ, multi-system involvement. So when we see a patient, we don't treat just the lung, we don't treat just the joints. We have to look at the patient in totality. We have to give a holistic kind of management, and weighing also the pros and the benefits, the side effects of treatment, and how it affects their quality of life, adverse effects of treatment. So this is where we have an active discussion often with the respiratory physician. And you've heard about the difference you've heard about the diagnosis of idiopathic pulmonary fibrosis, and then now we're talking about CTD-ILD. So it's actually fairly important to distinguish whether someone has IPF versus a CTD-ILD, because sometimes this affects the management. So if a patient has been diagnosed to have IPF, then the first line of therapy will be antifibrotic. Whereas if the patient has a CTD-ILD, then the treatment may sway more towards immunomodulatory therapy, because in these kinds of patients, we know that inflammation plays quite a large role. So this is where we contribute to the discussion of management. And the other aspect in terms of management also, you've heard about the high cost of the medications that we use. And we rheumatologists are actually quite familiar dealing with high-cost medications because we use biologics to treat the inflammatory arthritis, inflammatory arthropathy conditions. And these medications cost a lot of money as well, around 40,000 ringgit per year. So our pharmacy doesn't have that kind of budget to support this kind of high-cost drugs. So we have been, over the years, been looking at different ways of obtaining funding for our patient. So we have a team at the hospital, and this team consists of our rheumatology specialist nurse, the social worker, and the pharmacist. And there are many avenues for patients to get funding for these kinds of high-cost drugs. And this is where the allied health has quite a big role. And of course, the allied health professionals also play a very big role in terms of counseling. So these are very expensive medications, and we want the medications to work. Patients need to understand how they work. They need to know how it's administered, potential side effects to watch out for. So education and counseling is very important, and this is where the allied health also has quite a big role. You've heard about the importance of research, and we rheumatologists have also been actively participating in a lot of the trials related to interstitial lung disease, and many of the drugs now that we have in the armamentarium have come as a result of the participation of patients with rheumatic diseases. And of course, in terms of service policy, we are here to also contribute to the discussion about clinical pathways and the development of local and national guidelines. So yes, you've heard about this over and over again, but it's so important, isn't it? Cross-specialty collaborative working models. And I think in the Ministry of Health, this is something that we still haven't quite got around about. We're still very much working in silos, working within our various units. But time and time again, when you're talking about different diseases, we need to look at cross-specialty collaboration. And this can come in various forms. So it can be in the form of multidisciplinary meetings. So this is what we've been doing quite a lot virtually now, which is very effective, having combined clinics or multi-specialty clinics. So if I may, I would just like to share what we've been doing at Hospital Selayang. We have this clinic that we call the Cardiorespiratory Screening Clinic. It was established in 2013. But before that, maybe I'd just like to share a bit the rationale about setting up this clinic. So we know that interstitial lung disease is the most frequent complication and a major cause of mortality in this condition called systemic sclerosis. So even though the clinical significance, so how do we define the prevalence of interstitial lung disease in systemic sclerosis? So if we use lung function test, almost all patients will have abnormal lung function test. If you're looking at CT scan, around 2/3 of them will have an abnormal CT scan, but probably clinically significant disease. That means it's significant enough to cause symptoms, it's significant enough for us to treat. It's about 50% of these kinds of patients. The other thing is that you've heard just now, right, that it's quite difficult to diagnose. And this is something that we really see in our CDD patients. In the very early stages of this interstitial lung disease, the patient may be totally asymptomatic, or the symptom can be very subtle. And this is especially so we're looking at young, relatively fit patients, or some of them may have joint problems, and then therefore they may not be so mobile anyway. So all these can mask the symptoms. So it's very difficult to detect at the early stages or even predict who is likely to get this condition. And it's been stated that there is no demographic, clinical, or immunological parameter that allows us to definitely predict who amongst our systemic sclerosis patients will get interstitial lung disease. And so this is why it is now mandated or recommended that all our patients should be screened. Dr. Felix said that it's quite impossible to screen the whole country or the whole population for ILD, but this is a group of patients that we can screen, right? And so how do we screen? So we need to screen by doing various tests. including lung function test, a 6-minute walk test, and we also do CT scans, all right? So that's why we set up this clinic. So the main purpose was to screen. And by screening, we mean that we're just going to look for it in everybody, regardless or not of whether they have symptoms. So we've been very lucky at Hospital Selayang. So even though we don't have in-house respiratory physicians, we have been working very closely with our colleagues from University Technology Malaysia, UiTM. And so the respiratory unit is from there, and they've grown from a single person unit to now quite a fairly big unit. Now with trainees, and that's them on the left. And then that's my colleagues there over on the other photo. So this is a clinic that where even though we don't see the patients together, we see the patients individually, but then we can just walk across the rooms to discuss, and talk about whatever issues the patient's having. And then there you can see in the middle, that's our nurse, one of our nurses, and she's very useful. She's been instrumental in coordinating this clinic, and she's the one that makes sure the patients turn up and that all the tests are done. And then the nurses also help to do the 6-minute walk test. So the patients walk up and down the corridor for 6 minutes. And this is one of our fellows doing the nail fold capillaroscopy. So this is a procedure that we do to detect capillaroscopy changes. So in some patients whom we are not quite sure whether or not they have systemic sclerosis, this is a useful procedure for us to detect very early changes. And yeah, that's the 6-minute walk test there. So in conclusion, I would just like to stress again that the management of interstitial lung disease is really a cross-specialty, cross-disciplinary collaboration. And we are very grateful for partnerships and also for meetings like this where we can create awareness, and we need to work together. And this is because, as we've heard, we've got limited resources. We need to work together, and this is ultimately for the benefit and the best outcomes of our patients. So thank you.